Good evening, dear colleagues. Again, I want to welcome you to another Thursday evening, a Thursday evening where the webinar is once again sponsored by the Clinix Health Group. And this evening, we have a special guest. We have Dr. Okuthe, who will be discussing the subject matter of the approach to the patient with osteoporosis. We had a remarkable speaker about 3 weeks ago, Mrs. Mosiana, and she spoke to us from the perspective of a patient being diagnosed rather with osteoporosis. And you can remember quite clearly what an engaging, well prepared, informative, insightful, engaging conversation that was. So we just wanted to say thank you to her once more. But because we are pursuing the concept and the idea of a multidisciplinary approach in terms of assisting a patient from the point of diagnosis all the way through to management, and obviously from a primary healthcare point of view, which is what Mrs. Mosiana talked about. But we also then moving forward, once the diagnosis has been made, then how is it that we can provide the best level of care for patients that have been diagnosed with osteoporosis? So I just wanted to give you a number of housekeeping rules. You know the procedure by now, but I know that there are a number of people that are joining us for the first time. So we want to say thank you so very much to you for availing yourself and joining us this evening. It's rather cold outside. It's been snowing, I understand, in some parts of the country. It's a bit warmer at the moment, but we do thank you so much for making yourselves available and sacrificing some of your family time to be with us every evening that the Clinix Health Group sponsors these webinars. As I mentioned, we have a number of housekeeping rules. During the course of the presentation, we have Dr. Okuthe who will be presenting to us. And then in the chats, please feel free to put in any questions or make any comments. I know many of you will be saying welcome as you're joining. Please feel free. Those are always welcomed and well received. So please continue to do that. The questions will be read towards the end of the Q&A session. Dr. Okuthe was a specialist. He'll be able to answer all the difficult questions, and so we'll be right there. He's all geared and ready to go. He's comfortably at home as well, and he's been excited to be here with us this evening. So please feel free to put those questions in the chats, or if you would like, please put your hand up, raise it directly, and you'll be able to ask the question audibly for everyone to hear. We most certainly welcome that. And then again, I would like to iterate when it comes to the registration to join the actual webinar, you would have received the link, and it's important that you do click on the link and put in your contact information, your practice number, and your address and the other information that is requested so that you can get CPD points. So if somebody has logged on, registered, and just sends you the link, all that you're going to receive is access to the actual presentation, but not the points. So it's really important that you please click on the link and register for the points to be received. And if you're not receiving them, please make a comment in the chat group so that we can contact you later and just make sure that the HPCSA is able to provide you with your CPD points or any of the other registrations that we can provide you with certification, especially from the South African Nursing Council. So again, without much further ado, I just wanted to again just reiterate how we are trying to link the continuum of care for patients from a preventative point of view, and then from a primary healthcare assistance, diagnosis, and then moving forward to the actual management and treatment. So Dr. Okuthe, he is going to be talking us about the approach to the patient with osteoporosis. And he is a specialist physician working at the Clinix Health Group at Naledi Nganyezi Private Hospital out in Sebokeng. It's actually next to the Sebokeng Hospital out there, and he's qualified at Wits University. His qualifications include FCP, South Africa, MEd at Wits, which he completed in 2016. And so he's been quite excited to prepare this presentation, which he has sent through to us in advance. So we are able to put that into the chats. But for those of you that are always asking where you can access these presentations, we do post them on the Clinix Health Group webinar page on YouTube. So if you put in there Clinix Health Group webinars, you'll be able to see all the webinars that are presented here every Thursday going forward. Dr. Okuthe, it's over to you. We've been looking forward to this. We had an interesting discussion beforehand, and I'm sure that everybody's going to be riveted to their screen and be asking you all sorts of questions at the end of this presentation. Thank you once more for joining us. Thank you so much.
Thank you. First of all, let me thank everybody who has made time to be present for this presentation. It's a cold evening, like you've mentioned, and so just to make time to be here is itself important, and I really appreciate that you could be here. I just want to make it clear that I was not aware a similar presentation was made last week. It's certainly not something that we discussed with the previous presenter. And so this is purely a coincidence that I'm presenting something on a very similar or same topic. I have been told how well the previous presentation was, and I almost find it slightly intimidating. But I think without much ado, I'll try to present on the topic of osteoporosis with a more patient-centered focus as much as possible. I'll begin with the basics, which I believe are important, the introduction, and just a bit of epidemiology and pathophysiology before we deal with the more patient-centered aspects of disease. Just a little bit. I'm just trying to test my system. Yeah, so basically osteoporosis, as has been mentioned before, is the most common metabolic bone disease. And the reason I picked the topic, the reason I'm sure it was picked previously, is that it's not as commonly diagnosed as it should be. It's a lot more common than we come across. Osteoporosis is certainly a disease characterized by low bone mineral density. And the importance of this is that this leads to the low impact of fragility fractures. Now, by definition, a fragility fracture would be a fracture that is sustained following a fall from a standing height or lower. Now, usually osteoporosis affects the bone microstructure, and this is what predisposes to fractures. The most commonly affected sites, again, this is more a revision, is the vertebrae. The vertebrae is the most common. A study in the UK established that. The forearm and the hip. The hip probably is the most significant because it has the most severe consequences. Usually that's the proximal femur. Now, just to mention, osteoporosis is more common in women than in men, and 1 in every 3 women over the age of 50 will get an osteoporotic fracture, and 1 in every 5 men will also get an osteoporotic fracture. These are just important, probably epidemiological points to take note of. Now, in terms of how prevalent it is, it's projected that by 2050 the incidence will have doubled, and the mortality rate is high, especially for hip fractures. 20% of people who get a hip fracture usually will die within the first year, and the risk persists for about 5 years. Now, hip fractures are commonest between the ages of 75 and 79. And just from South African statistics, I think I need to, sorry, let me just get back to that. We have about, oh, sorry guys, there's a bit of about 25,000. My screen is a bit covered. Just hold on there a minute. Sorry. Just I'm trying to. All right. I think that's much better. So we have about 25,000 hip fractures annually, mostly occurring in the Black African population. This is largely because obviously there are more than the other races. Now, hip fractures in South Africa will be common in all races, regardless of gender. And the incidence is projected to rise gradually between 2020 and 2050 in the manner illustrated. Now, I think the reason I'm focusing a lot on hip fractures is it's the most impactful of all osteoporotic fractures in terms of survival and in terms of the risk of subsequent fractures, which would be referred to as imminent fractures. Following an incident of hip fractures, the recurrence of major osteoporotic fractures rises significantly within the first 2 years. And in fact, this persists like we saw over the next at least five years. Now, just in terms of the pattern of occurrence, osteoporotic fractures will usually start with the wrist, and the next most common site for osteoporotic fracture would be the humerus, and subsequently the vertebrae, the hip occurring much later in life. However, hip fractures tend to have the most severe morbidity and perhaps tend to be the most encountered in clinical practice. Now, osteoporosis, in terms of pathophysiology, would occur because of a disruption in the balance between bone resorption and bone formation. Now, osteoporosis occurs when osteoclastic activity outruns osteoblastic activity. Now, bone resorption exceeds bone formation, and under normal circumstances, what would happen is from birth to the ages of early 20s and late 20s to early 30s, there's increased bone formation, and this is influenced by different factors depending on one's circumstances. Genetics play a big role, nutrition plays a big role, and other things such as physical activity, intercurrent illnesses play a big role. And by the ages of about 20 to 30s, most people will reach their peak bone mass. And what peak bone mass an individual achieves will depend on the circumstances under which they have grown. And therefore, different races and the presence of infections will all play a role at the end of the day. Now, with aging, usually beyond menopause, and as men grow older and their androgen production declines, bone formation declines and resorption exceeds bone formation. And the final effect is that there is a net loss of bone, and this results in a deterioration in the bone architecture, which then predisposes to osteoporotic fractures. Now, the key mechanisms driving bone loss in this case would be estrogen deficiency post-menopause. The role of estrogen is to inhibit osteoclastic activity. With age, the osteoblastic number and function decline, and therefore bone formation declines. Now there is secondary etiologies that influence osteoporosis as well. A lot of them are endocrine, and this would include things like hyperparathyroidism, thyroid disease, diabetes. Drugs, like has been covered before, would include glucocorticoids, and malabsorption would occur in the settings of inflammatory bowel disease and celiac disease, this kind of situations. And all these influence osteoporosis. Now, after menopause, usually there's a very drastic decline in bone density as a result of a decrease in formation and increased osteoclastic activity. The rate would usually be around 2 to 4% per year. Importantly, in the first 10 years, about 25 to 30% of bone density declines. Now, factors such as HIV and, like we mentioned before, childhood malnutrition, infections do play a role. With specific mention of HIV, the disease itself does have a role, but also treatment may play a role. More specifically, tenofovir has been associated with some degree of osteoporosis. I thought it's just important to mention that. Now, so in terms of probably more a summary slide, in terms of the causes and risk factors, there's primary osteoporosis and secondary osteoporosis. The primary type is largely the postmenopausal osteoporosis, but yes, age-related osteoporosis is also there, affecting essentially people above the age of 70 mostly. Things like family history are important, and the BMI is important. Usually excessively lean body mass index predisposes to osteoporosis. And how much peak bone mass one attains before the age of around 30 also plays its role. Now, the secondary causes, I may have mentioned this earlier on, would include largely the endocrine causes. Drugs, usually glucocorticoids, would be important in even what may seemingly appear to be small doses. Glucocorticoid use of at least 5 milligrams or more per day for a period of at least 3 months would have fairly significant consequences. And that would be regarded as sufficient to cause fairly significant osteoporosis. As a matter of fact, anyone on those kind of doses for that sort of period usually would need to be put on treatment. Now, lifestyle causes largely include smoking, alcohol use, usually at least 2 drinks per day, and which 2 drinks would be any form of alcohol, whether it's whiskey, beer, whatever, at least 2 drinks per day, and poor nutrition in terms of, I think, more significantly, calcium and vitamin D. Sedentary lifestyle all contribute to an increased incidence of osteoporosis. Now, the GIT causes, again, we may have mentioned, is malabsorption, chronic liver disease, which affects absorption as well. Inflammatory bowel disease will affect absorption as well as cause inflammation that in itself may also accelerate osteoporosis. As a matter of fact, chronic inflammatory conditions such as rheumatoid arthritis, lupus, also may influence osteoporosis, even though they may not have significant effect on the GIT. And this would come under the category of other chronic systemic diseases. Now, in terms of, I think the presentation would be probably straightforward. Usually, osteoporotic fractures, which are fragility fractures, would occur as a result of a minor fall. Usually, one would be surprised that it has caused a fracture. Given that it's a fall from a height, it would be expected that the site most likely to be affected would probably be the weight-bearing areas, the hip, the spine, and the forearm because of the support. Now, vertebral fractures are common. This would normally present as backache, either sudden onset or chronic. And obviously, following a fracture, mobility becomes an issue, and there is functional decline. The hip, I particularly mention that because it affects the quality of life more than any other osteoporotic fracture. In terms of vertebral fractures, it's just important to note that patients may not necessarily complain of pain, but when posture changes, and more specifically when height changes, this would be important probably more in patients that one knows already. When height declines by at least 4 centimeters, that would be diagnostic and does not necessarily require radiology to confirm, but obviously that is important to do. Now, in terms of diagnosis, I think this was probably covered a lot. The gold standard for diagnosis would be the DEXA. This is not always available, and for that reason, the FRAX tool was designed to assist in determining diagnosis, especially where access to DEXA might not be there, and even in determining decisions regarding treatment. It does play a big role. And obviously, then there's the radiologic methods that we use for diagnosing and even classifying various degrees of osteoporosis. Vertebral fracture classification, I think that was probably very well covered, and I may not go over that again. So we before we go to treatment, I think the most important message after my initial warm-up presentation is that when any patient presents with osteoporosis, perhaps the most important thing is to investigate them for possible secondary causes of osteoporosis. At least to check their nutritional status, their vitamin D levels, their calcium levels, serum protein electrophoresis, and where suspicion is present, investigate for malignancies, because where this exists, obviously their intervention would influence the patient's outcome in a big way. And in terms of treatment, what would probably be more important is to decide who to treat and who not to treat. Based purely on the DEXA classification, any patient with a T-score of less than minus 2.5 would be diagnosed as being osteoporotic. But all patients who classify as being high risk, and high risk is established quite easily using the FRAX tool. And unfortunately, I did not present the FRAX tool. I'm not presenting the FRAX tool, but it helps a lot in classifying patients in terms of their 10-year osteoporotic risk. Those who fall under the high-risk category all require treatment. Usually, they are patients with patients with prior significant fragility fractures, and the most significant usually would be the hip and the vertebrae, and patients with T-scores of below minus 2.5. These patients are at high risk based on the FRAX classification tool would fall obviously above the intervention threshold, as would those who are definitely very high risk. Now, the very high risk patients, again, I'm just going through that, would be patients who have had a spinal or hip fracture in the preceding 2 years, or those with multiple fragility fractures, and those with a T-score of at least minus 3. Based on, or just to reiterate what I mentioned earlier, any patient on high-dose steroids, and high dose would then be 7.5 and above per day. If this is expected to to progress beyond 3 months, would require to be started on treatment for osteoporosis right away. You don't have to wait until they complain or until there's an incident. The incidence of osteoporotic fractures in this group is quite high, and it is advisable that they be started on treatment right from the start. Now, the FRAX assessment tool, I think this is just a very slight summary. It's a detailed tool, and it's available online. I just put this slide to sort of give an indication of the sort of readings you could get from it. It calculates the 10-year probability of major osteoporotic fractures, as well as hip fractures. The FRAX tool is available for different countries. We have many models. I think about 81 models are available worldwide in about 73 countries. South Africa has its own specific model. You apply FRAX tool to a patient based on their country of birth, and basically you download it, enter the data, and it gives you the 10-year major osteoporotic probability risk. And depending on where they lie, you can then determine whether they There are low risk, intermediate risk, high risk, or very high risk. And this then gives you whether they fall within the intervention thresholds or not. And the slide just summarizes for each age group where the 10-year probability to treat is, and with the FRAX probability scores, you don't necessarily have to have a BMD score. Now, just a caution regarding the FRAX scoring. It's not catered for to cover for certain variations, especially the presence of secondary causes of osteoporosis, and so it may not apply equally to, or it may not be as effective where the cause of osteoporosis is secondary as would be primary. Certain additions are made, for example, where one has diabetes or HIV, there's certain additions in the calculation that you make. So it has to be used with this in mind. Patients who've had prior fragility fractures, again, may not be as well represented as those who are having a sentinel fracture. Now, a fracture a fracture, let me say, yeah, I think that was just mentioning that imminent fracture risks. Patients who get imminent fractures, an imminent fracture, like I explained before, is a fracture that follows a previous major osteoporotic fracture. The FRAX tool does not really cover for the risk of imminent fractures. So I think, again, that would be a shortfall. And it does not cover for things like patients who have a high fall risk. So it's just really mentioning that the FRAX tool is good, but it has its own limitations. Patients with recurrent falls would be anyone who has at least more than 2 significant falls per year. And again, it does not cover patients on high dose glucocorticoids as well. Now, in terms of treatment, perhaps one of the most important things to mention is that obviously osteoporotic fractures, like we mentioned, are most common in postmenopausal women, but in older men as well. And I think in line with that, one of the most important things is to try and determine menopause in good time and institute treatment for menopause with the benefits of preventing osteoporosis, but also additionally, obviously, with the benefits on cardiovascular disease. And so menopausal hormone replacement therapy is actually one of the most important treatments for osteoporosis. Now, other than that, where one is diagnosed with osteoporosis, there's other modalities of treatment obviously available. Bisphosphonates play a big role. This could be given either orally or intravenously. The oral options are more readily available, easier to administer, and perhaps more affordable. And so oral bisphosphonates, usually given weekly for a period of about 5 years, would probably be the most commonly used. Now, other than that, the nutritional aspects have to be taken care of, specifically calcium, vitamin D, just a balanced nutrition. The lifestyle changes need to be instituted, like we have mentioned before. But beyond that, intravenous bisphosphonates probably would be for the most severe forms of disease and in significant forms of secondary osteoporosis in patients who have malignancies, who get fractures. Intravenous bisphosphonates have the advantage of being given less frequently and therefore perhaps more likely to offer better compliance than oral bisphosphonates. Now, xalindronic acid is, I believe, the most readily available, usually given intravenously at doses of between, it's available either as a 4 milligram or a 5 milligram injection. I think importantly, before it's administered, we have to ensure that a patient's kidney function is normal. And it would be advisable to hydrate the patient before administering and if possible, shortly after. I would normally give about 500 mils of fluid and you administer it in about an hour. And after that, you can give another 250 mils, and that should be okay. And so bisphosphonates are probably the most readily available. Now, beyond that, we have the anabolic agents and denosumab, which goes by the name of Prolia, would be the other first-line drug that we can use for treatment of osteoporosis. Now, in those with the very high risk, this would be patients in whom the risk of fractures is quite high and you need bone formation to be rapid. You then need an agent that is anabolic. And denosumab is one of those that we have. Teriparatide is available in South Africa, but I don't think it's readily accessible and probably would be better reserved for endocrinologists to prescribe. But I think denosumab is more readily available. It's an anabolic agent. It increases rapid bone formation. And one thing to remember is that following the use of the anabolic agents, upon stopping, bone loss may be rapid. And so upon stopping them, anti-resorptive therapy needs to be given to sustain the bone mass or the bone mineral density. And just as a summary, for the low risk patients, really what we give is more the lifestyle changes, and menopausal hormone replacement therapy, I think, remains important for reasons beyond just osteoporosis. I think the last part of that is really more on high dose glucocorticoids, which we've mentioned already. Now, I think the last slide just is more a guideline on the sequencing of treatment, in the sense that osteoporosis is not entirely cured. It remains a lifelong risk. And the fact that one has been treated for osteoporosis for the first 5 years does not mean that the risk is over. Bisphosphonates have the advantage that, after the first 5 years of treatment, they may give you another 1 to 2 years of protection upon discontinuation, but medications such as denosumab do not offer that. And so when you start treatment, you have to already plan what will happen at the end of that particular treatment regime. Now, just as the slide goes, usually after 5 years of bisphosphonate, especially the oral one, the options would either be to switch to intravenous after the 2-year grace period, or depending on what your DEXA profile is, you may choose to give denosumab. Evidence available would favor that once one has used bisphosphonate, perhaps denosumab would then be a better second-line agent. And I think most of us would probably treat in that range. I think the next slide that includes the use of teriparatide and romosozumab would probably be the sort of patients that we are likely to refer to an endocrinologist, because I think that would not be readily accessible to most of us. I think the remaining parts of this, again, we have basically covered regarding the effect of the anabolic agents and how quickly bone resorption would occur upon discontinuation. And therefore, one needs to plan the exit strategy as soon as you complete the regime. And I think I've tried to just put everything in as much of a summarized form as possible. I hope that was good enough. Thank you.
Of course, it was more than good enough. Thank you so very much, Dr. Okuthe. Ever humble, and I'm sure you'll see the acknowledgement and yeah, recognition from your colleagues, as you can see being demonstrated right now. So thank you very, very much for that presentation. It was quite informative, and the transition from the primary management of patients, especially with a diagnostic point of view, as Musiana pointed out, and then leading to what it is that you're giving us guidance and further management of these patients. Got a number of interesting questions for you already. But before we get into the question and answer session, I just want to remind all our colleagues about the South African Health Excellence Awards that is coming up in the month of November. You'll see in the link that was posted earlier on. What we will be doing is we will be allowing you to click on the link, or you can scan the QR code that you currently see on your screen, and you will be able to nominate yourself or any of your colleagues for various categories that are made available. So please, please, please do nominate your colleagues. It is quite a prestigious event. It is really remarkable to see the kind of excellence that is prevalent amongst our colleagues. And I'm not just talking about specialists or general practitioners or physiotherapists or any other allied healthcare. This goes all the way to students that are currently at university that are doing remarkable work in the communities, raising money for underprivileged communities where patients are requiring assistance, and just a variety of different areas of interest. So please feel free to go onto that link and nominate yourself or your colleagues that you would like to put forward. And this is for the month of November. So we'll be reminding you as we get closer to that time. A special thanks to Sister Govender, Sister Venezuela, sorry, Sister Govender, I beg your pardon. Sister Govender is actually on holiday and she's out there in the UK. She's been there for 3 weeks, and every week she's studiously, diligently attending the webinar. So, Sister Governor, thank you so much for doing that. I know that there are people from other parts of the world as well, in Canada, Namibia. So just thank you so very much. Dr. Okuthe, you are in good company, and people are coming in from all over the world to attend your presentation this evening. So thank you so much for that. And then again, a special thank you to uh, Ms. Ranjit. She sent me a number of people that she wanted to join in, about 15 people that she just sent email addresses for and said everybody needed to come on board. So thank you very much, Rajeshri, for sending us through from Durban, that is, KZN, out there. I understand it's not much warmer than it is out here in Gauteng, but thank you so much for asking your colleagues and sending their names forward to join with us. Just like that, 15 email addresses and saying everybody in Durban also wants to get involved. So thank you to you for that and bringing your colleagues on board. Thank you for that. So I have a number of very interesting questions. You were talking about the diagnosis, and I'm trying to remember from memory, you said about 25,000 plus fractures that are identified in South Africa alone. And I'm thinking you were talking about the hip fractures at the time. And then you
Mm.
were talking about, you specifically focused, you said the Black community.
Mm.
Now, what about, where did you get the statistics from? And what about the white community? Because growing up, medical school,
Mm.
it was more the older white female kind of population. I know our diet have integrated and we're all living similar lifestyles now, but at that stage, that's how it was put forward. And now
Mm.
you are presenting different statistics.
And not different statistics. In terms of the incidence rates,
Hmm.
in terms of the incidence rates, in terms of the race most likely to have osteoporosis and osteoporotic fractures,
Yeah.
it's actually more prevalent among the white population,
Okay.
followed by the Indian population, colored, and then blacks.
Okay.
But in terms of just absolute numbers of fractures, I think
Yeah.
this is just to give an indication
Understood.
of the extent of the problem
Yeah.
countrywide.
Yeah.
Yes. Yes.
Okay,
So
so then, yeah,
just
so the perspective is that if in
that's
black
right.
people it's 25,000, and obviously
Yes.
it's much more in other categories. Yeah, just to get clarity as far as that was concerned. And then interesting enough, you mentioned males. I think you said the number was one in five
In
males.
five,
Yeah, would
above the
also
age of 50.
suffer a
Yeah.
fracture. And then you talked about, I'm just trying to go back now, when you talked about, for instance, hormone replacement in females. And then you
Mhm.
mentioned early diagnosis or recognition of menopause.
Menopause. Mhm.
Yeah. And then you talked about the hormone approach. Would males be more affected because of lifestyle and alcohol and all the other diseases that you mentioned, taking treatment for diabetes? Because what would you then support in terms of saying your early diagnosis of what in males and what would be the best management for them?
So I, I think
I know it's
it,
Women's Month and it
it,
was Women's Day. Because of them, we got a holiday on Monday, but we really also need to pay attention to the guys. Yeah.
so I think first of all, in terms of women, the diagnosis is a lot easier because menopause comes with a whole range of symptoms that have been studied well and are readily recognizable. And so anybody looking for them is likely to pick them up
Yeah.
if you're looking for them. And like we mentioned, the role of estrogen is to inhibit osteoclastic activity, and therefore, providing that has its role. But also among the men, with age, the androgen levels drop. And so a decline in androgen levels decreases the osteoblast number and activity, and therefore osteoporosis becomes a bigger problem. It's just not as commonly tested
Yeah.
as estrogen FSH levels. But I think if we are on the lookout,
Mm.
if we are on the lookout and we test for hypogonadism, test for testosterone levels, and test for LH, then we may actually pick these things a bit earlier if we are deliberate about it.
Yeah.
Yeah,
So just with that, I know Professor Dirk Du Plessis, who presented an excellent presentation a few weeks ago,
yeah.
talking about oxygen.
Mm,
And so here's a question here, and I'm going to put it exactly the way he puts it because of his sense of humor and the way that he phrases or says anything that he does. He says here, as osteoporosis presents in old or older age people,
mhm,
it is recognized after the horse is bolted. Does
mhm.
calcium supplements help at all?
Just repeat that again.
So basically, osteoporosis is
Mm,
picked up in the older
yeah,
generation and group after
yeah.
basically the depletion of calcium. But does the calcium replacement therapy assist supplements
You mean in the prevention?
specifically for calcium?
Yeah, yeah. I think, like we said, among the lifestyle changes that one needs to make
Hmm.
to prevent osteoporosis, other than stopping smoking
Yeah.
and cutting down or, you know, just minimizing alcohol, the diet was the other important part. And it would have to be a diet that is rich in vitamin D and calcium. Now, if your diet is rich in these, I think that would be sufficient. Where, of course, there's deficiency of calcium, then supplementation plays a role. But on a population level, I think what we need to promote is a good diet in terms of the presence of vitamin D and calcium.
Dr. Okuthe, you said something really interesting. I'm starting to think that the alcohol companies are going to have an issue with these webinars because last week we were discussing the fractures around the femur head, right? So now you are talking about alcohol, and you've mentioned it a number of times.
Yeah.
There was a time where we were told that drinking alcohol,
Mhm.
at least a glass per evening, and that was supposed to be wine, and then it was said no, alcohol in general was
Mhm.
supposed to be good for your heart. But as time is going on, we're realizing this is not true, and you're saying it's definitely not the best approach when it comes to avoiding something like osteoporosis.
I think what is known for a long time, it's not new. What is known for a long time is that there is certain daily limits that amount to healthy alcohol consumption. And this has been established to be 2 units. Now, it might be 2 shots of whiskey, 2 glasses of wine, or 2 pints of beer. Obviously, it's unlikely that it makes sense to drink this every day, you know. But the point is, the fact that one does not drink for 7 days does not mean you can then cover for what you've missed at the end of the week. It still remains that 2 units per day is the healthy limit for alcohol use, and beyond that, definitely there's adverse. Uh,
Thanks. Yeah, I've got Professor Derek's hand is up directly, and he's going to ask the question. So please go ahead. Thank you so much, Professor.
Hi, Dr. Okuthe. Thanks
yes,
for all that, but my question is rather a bit more specific. You
yeah.
said because we deal in open heart surgery, also with the scourge of valvular disease from a very young age. Now, obviously, if you now try to place a prosthetic valve in small or children, young age, uh, you've got a problem of you cannot put in a biological valve. In other words, you now condemn the individual to a
Mm,
mechanical valve that needs warfarin and Okuthe. Now, the reason for that is the
mm,
younger you are, the more active your calcium metabolism is.
mm,
So, in
mm,
the ages, you can say from birth to 10 years old, you've got a super hyper, triple, quadruple hyperactive calcium metabolism. So, in
mhm,
other words, what happens is in a very short period of time, literally months, a
mm,
biological valve will calcify.
mm,
So, as you get older, you get past your teens, then that sort of issue becomes less and less. But as you get in your middle age,
mm,
your calcium metabolism actually decreases quite quickly again. So I was very, very active early in your life, but that's
mm,
when all the stuff is laid down, your
mm.
bone growth,
Yes, yes.
your mineralization, everything that's the good basis that's going to supposed to last you for the
Mm,
rest of your life.
mm,
Now,
mm,
if that isn't done then, thus if you don't drink your milk then, if you don't get your proper calcium loads and all that then,
mm,
you actually start at a serious deficit. And to try and make it up when you're 70 years old,
mm,
Yeah.
it's like trying to fight with an elephant.
mm,
In
mm,
other words, you are losing all the time because your
mm,
calcium metabolism has slowed down.
Yeah.
So, yes, you can stimulate it with all sorts of aggressive interventions, but
mm,
that is also carries significant risk with it. So, it's not like it's a freebie. You can
mm,
just do it, then everything's going to be okay.
mm,
It
Yeah.
will not be okay. So
mm,
my argument is at best you can actually do is slow it down.
mm,
That's it. And I've got a problem with all the supplements you can buy over the counter
mm,
because that's a huge pharma market where
Hmm.
people make lots of money.
mm.
And buy this calcium, buy that calcium. My personal feeling is
Mm.
you're buying water for you. so, so I don't think it does makes any difference to
To,
your real calcium metabolism at all
uh,
because you've already lost.
Yeah. Yeah, you're
yeah,
already down.
yeah.
So you say be preventative, eh?
I,
Anyway, that was just
I,
I
I, I,
wanted just wanted to transmit.
I think
Thank you
Prof
so much.
is giving a comment. Yeah.
Yeah.
Okay, which is valid. I mean, like we mentioned, the peak bone mass is reached usually by late 20s to early 30s.
Yeah,
Yeah, so I agree that that would really be the best time. I mean, it would be best to influence your peak bone mass,
Prior.
yeah, prior.
I don't know. I don't know. It's like you are delivering, gentlemen, negative news here to all our attendees. I'm sure there are those that are younger than 20. But for everyone else, please keep in good health. So what I wanted to find out from you, especially with diagnosis, prior to going and looking at the treatment and causes and so on,
Mm.
is you were talking about the T-scoring. For instance, how do you interpret a T-score discrepancy between the lumbar spine and then the total hip? Do you do any form of work with regards to that?
Yeah, yeah. There is some rounding up that is done.
Mm,
I think I would have to. There's a specific rounding up that's done when there's a difference between the lumbar spine and the hip score,
yeah.
and I think that's where things like the trabecular bone scoring also come in.
Mm.
Yeah, but I
Yeah,
think
because
I'll.
it's interesting, you were asking, so you were talking, for instance, about primary, secondary
Mm,
osteoporosis. And so basically when a patient suffers fragility fracture, right?
mm,
And yet their bone density and mineral density is normal.
Mm.
What sort of workup would you do to exclude? Yeah.
As a matter of fact, the T score is not the only thing that influences fragility fractures.
Yeah.
What's been found is that majority of people with fragility fractures actually have T scores above minus 2.5.
Mm.
Yes. So there's other factors, including the bone microarchitecture and the speed with which bone is formed, which influence it beyond just the bone mineral density. And yes, anybody with a fragility fracture, whether their BMD is low or not,
Mm.
still have to be investigated for secondary causes. And the most common secondary causes obviously would depend on the patient as well, but certain things would be quite basic. Like we said, endocrine investigations have to be done. Thyroid, parathyroid, diabetes, those have to be checked. Malignancies have to be checked, specifically myeloma, quite common.
Mm.
And so SPEP has to be checked. Obviously, calcium, vitamin D need to be checked. You have to assess both in your history and in your investigations for GAT causes, including things like celiac disease, depending on how your patient is presenting. And yeah, I think so. The range of investigations will depend on how good a history you take,
Yeah.
but also on which sort of patient you're dealing with.
So in essence, these glucocorticoids, because I know that it was a question the last time
Mm,
that Mrs. Musiana presented on the diagnostic factors in a primary healthcare setting and management of osteoporosis there. And the
mm,
question was around these glucocorticoids, people with diabetes.
mm.
And so basically, is it that they, at cellular level, that they lead to the suppression of osteoblast bone formation and as well as increasing bone resorption at cellular level?
Their effect on osteoblastic activity, I think I would have to check that specifically, but definitely they increase bone resorption.
Okay.
Yeah.
Yeah.
They
So, and then
increase-
also, then you were talking a little bit about
Mm,
looking at anti-resorptive agents, right? Because I'm just trying to link now what I was talking about, the resorption part of it. So,
mm,
so these anti-resorptive, the biphosphonates, for instance,
mm.
at which point, from a clinical point of view, do you find it appropriate to transition from those to looking at the teriparatide, for instance, the anabolic agents? Is there a time where you can say clinically, let us move from one to the other or not something recommended?
One of the things that would guide is the risk status of the patient,
Mm,
how high risk a patient is. I think that's one. And things like patients who have multiple fragility fractures.
mm,
Patient who has multiple fragility fractures, a patient with a T score of below -3 is at a high risk of significant fractures.
mm,
And there's some sort of agency to try and build up the bone mass. And where the need to build up the bone mass a bit rapidly is there, you need a drug that increases the bone mass
yeah,
rather than just slowing down the rate at which resorption happens.
okay.
I think that's the concept.
Yeah, thank you so very much. I have a question here also that says, is working with water a cause for osteoporosis? I'm not sure to what degree or what aspect, but that's the question that's put forward here by Dilsia Mahlase.
He is working
You're
with water.
smiling. Yes.
I'm not following the question. Working with water
Yeah, I'm sure you can unmute
in
yourself, Dilcia, and then
in
please
what
do
sense?
share. Yeah, yeah, no, and you can definitely share that with us. So these are specific conditions. So it's just important. What I'm trying to get at ultimately is that sometimes we are treating patients where we feel with other medical conditions and we believe that we have good controls,
Yeah,
but we're not paying attention to the complications that could result
yeah,
as a
yeah.
result of the medication. And then we need to keep an eye on other aspects as well.
Okay.
So when are you looking for patients to be referred to you? And this is looking at a primary healthcare setting, whether it's a GP practice, whether it's doctors in other disciplines, because we're trying to look at it from a multidisciplinary point of view. We know that a lot of our colleagues that are from the chiropractors, especially now that Mrs. Jayashri has given us quite a number of people, or Jayashri, sorry, has given us quite a number of people to join. So everybody wants to know, because you don't want to be hurting patients. So at which point do you refer to you and saying, please take a look at this patient, help with further investigation?
I believe at a physician level,
Yeah.
perhaps any patient who has had a fracture as a result of osteoporosis. Now for patients with osteoporosis minus a fracture, I think they can be treated at a primary care level.
Okay.
So the aim at the primary care level is actually to identify osteoporosis before they
Before,
fracture.
sure.
Yes.
Okay.
And prevent fracturing.
Excuse me. So you're
I
saying
think that should be
at
the main.
primary healthcare level already, we could have
Yeah.
significant impact in the management and
Yes.
taking care of those patients, that it doesn't necessarily need to go to the level of a specialist physician.
That's right. Especially patients who would benefit from oral bisphosphonate that's given once a week. I
Sure.
think that should be given at a primary care level.
Yeah.
And that would help a lot, I think.
Excellent.
Mm, mm,
Yeah, I am trying to see if there are any other questions that are in the chat or any of those that I've missed. But I'm sure if there are, then we most certainly will be able to answer those. For those who have direct questions, we could always send it through to Dr. Okuthe. Uh,
mm.
you were really kind, very humble, very informative, and you're always really encouraging. So thank you very much for again presenting yourself this evening and putting together this package. I know you said you were going to be accommodated. Yeah.
I must say, one of the strangest things,
Yes.
I felt awkward because I thought I was talking to myself the whole time.
You should have told me to keep my camera on, then I was gonna
Maybe.
nod and look interested. No, but everybody, people are putting in the chats, they're saying good evening, and people are commenting. You didn't see the hands go up during the course of the presentation, nothing. So everybody's quite engaged, and you can see so many people are still on board
Uh,
with us. So no, you most certainly were not speaking to yourself. Were you thinking like you are like on the news speaking to the camera?
mm, mm. But yeah, I just
Yeah.
wanted to,
Yeah,
yeah.
exactly like that. No, it was informative, really remarkable. And
Mm,
as you can see, everybody's saying thank you very much for
mm,
you presenting this topic so well.
mm,
We look forward to hearing from you again in the future. And again, I just wanted to say thank you to the Clinix Health Group for sponsoring these Thursday webinars. We look forward to another remarkable session well, next week. There are quite a number of really informative webinars that are coming up. Again, as you know, the research team is back on there. And so Professor Maswime. So Lomi Maswime always has remarkable speakers that come on every so often, and they will be presenting again next week. Quite informative, as you know, from a research point of view, and you're able to take that and apply it to your clinical practice.
mm,
So thank you very much to the team in the background. Thank you, Neil. Thank you, Tolakele and Sister Nasisa. Thank you for making sure that everything is running smoothly. Trying to help Dr. Okuthe there find out how to share his presentation, but eventually we got it on. We just wanted to say thank you very much to everybody else for being part of the team and making sure that you keep us excited about presenting every Thursday. I hope you're going to keep warm for the rest of the night. No more sick days, no time off work for you. It's just tomorrow and then it's the weekend. Please keep warm. And thank you very much for your availability and for making these things happen. I really appreciate your time and have a good evening. Thank you so much, everyone.